My name is Dr. Lindsey Rolston, and what I'd like to talk to you about here today is the arthritic hip and how we make a diagnosis of arthritis in the hip and how we determine treatment for such a problem. I think it's important for us all to understand why we have pain, where the pain's coming from, and why surgery may or may not be necessary, and why we simply can't squirt some medicine in the joint and make it better, or take a pill and just simply cure the problem. Unfortunately, that is far from the case when it comes to arthritis in general, and specifically for arthritis of the hip. So this is a model of a hip joint, and we have a covering that's about 5 millimeters thick that covers both the socket portion and also the ball portion of the hip. That covering has no nerves, and so our normal hip does not hurt. When we lose that covering and we get bone on bone, it is nerve on nerve. And unfortunately, there's no human that can grow that covering back. Therefore, patients typically have pain. And the important thing that I'm looking for is, where is that pain? The pain that correlates with a hip that is arthritic is one that is typically in the groin or in the front portion of the hip. Not always, but usually it's in the hip and the front of the hip and the groin. It is usually made way worse with flexion and rotation of the hip. And so getting in and out of a car, perhaps just with walking, but rotational type maneuvers, getting out of a chair, are very painful for people that have an arthritic hip. This is in contrast. In general, people that have pain in the buttocks oftentimes refer to their pain as hip pain, but pain in the buttocks or the back of the thigh that radiates and travels is typically a nerve from the spine, so it's typically a spine problem. Pain from the actual hip, which is what we're talking about today, is pain that is in the groin or the front of the hip, worse with rotational maneuvers of the hip itself. So once we know that the patient has had pain that correlates with what we know to be hip joint type pain, we then look at our x-rays and try to determine whether the pain from the hip is correlative with what we're seeing on the x-ray. So we have a covering that is typically in place. So this hip is not entirely normal, but it certainly has space between the bones. That space is represented by the covering that has no nerve tissue. So this is relatively normal, and this is opposed to the hip that is arthritic. As you can see, there is no surface. This is bone on bone. There are little cysts. The head is deformed. There's little spurs, and this is cysts, as you can see here, and little spurs that have formed. The spurs are not the source of the pain. Spurs are in reaction to the loss of the covering. So a lot of people, I think, well, can you just take the spurs off and make the problem go away? And unfortunately, no, you can't. The pain is coming from bone on bone, which is what we see here. And there's no covering, and there's no one on the planet that can bring that back. And therefore, this is what severe end-stage osteoarthritis looks like. So how do we treat it? Well, we know that it's a permanent problem. We know that it only gets worse. Things that can be tried include soft-soled shoes, anti-inflammatory type medicines like ibuprofen, Motrin, Advil, Aleve, those types of things all work about the same. Injections of cortisone are possible, but extremely difficult in the hip as compared to the knee. So they're very difficult to perform because of the location and there's no space to get the medicine inside the hip. So therefore, we can have patients wear the shoes to cushion as they walk. They can take medicines, but unfortunately, if their symptoms are severe and they're limping and they don't want to live with the pain any longer, the option becomes total hip replacement. And what we do with a hip replacement is simply take off the bad surface, the ball is taken away, and we basically put in a new socket, and then we put a new stem down inside the thigh bone. This is a model of that with the implant in place. And then there's a ball that's made of either cobalt chrome or ceramic that fits within the socket and allows the bone-on-bone situation to be taken away. And that's why the pain gets better. Hip replacement surgery is extremely successful. The pain predictably goes away, even better than knee replacement, and is a very, very good operation. It is a surgery that takes approximately 1 hour. It can be done with an approach from the front of the hip or the back of the hip. There's advantages and disadvantages of each. We try to do the surgery from the front. It is half the incision. There is a much lower rate of dislocation, meaning the hip popping out of the socket, which is a complication by all doctors that perform hip replacement surgery. And so we try our best to be able to do it from the front if a patient is a good candidate for that. And that is determined on a case-by-case basis. I would say that 80% of our patients receive the surgery from the front, so with an anterior approach, if you will. This would be what a hip replacement would look like after the surgery. This is a socket made of metal. The bone grows into it, and likewise there's a stem down in the hollow part where the bone grows into it. The ball you barely see because it's metal and it looks as if it overlaps, but this is why the surgery is successful, because again, we take away that bone-on-bone phenomenon where the pain is located. Patients typically are in the hospital 1 to 2 days. They're able to be full weight bearing right away with a walker and a therapist. They can switch from a walker to the cane within the first week or two. We take staples out in the office typically at 2 weeks, and then at 6 weeks we take x-rays again to make sure that the implant looks to be in good position. And most people, this person is someone I saw today, and they've been golfing for 3 weeks. Now that's not always the case. This person happened to be a near professional golfer prior to surgery, but just shows you the capability. So he is walking at 6 weeks, no cane, no crutch, no limp. And full recovery we would expect to be 3 to 6 months. We give antibiotics to prevent infection. We give typically aspirin to thin the blood a little bit to prevent blood clots. And there is therapy that typically would be home type therapy, where the therapist would come to the home and do extra therapy 2 or 3 times a week for the first couple of weeks. Sometimes additional therapy may be necessary, and if there's an issue with having appropriate care at home, sometimes patients would actually go to a rehab type facility for a few weeks and then return to the home. Hip replacement surgery, again, has been done for the last 50 to 60 years. It is extremely successful. If there's any questions about hip replacement surgery or whether you're a candidate, please feel free to contact me at any time.